Dr. Kushner also changes the force of the vector of the inferior oblique from elevation and calls it anti-elevation, and that's really correct because it's not a depressor itself. It's an elevation. It's an elevator muscle. So when you change it from positions, it still acts when the commence elevates. When the eye elevates, the inferior oblique starts to act. So if you put it, if you change its position, it will act as when the eye is commanded to elevate. So they also found that this causes restriction when they do this, put in this anterior to the equator. It causes to restriction and this syndrome that was called anti-elevation syndrome, this restriction is more in elevation and abduction and mimics a contralateral inferior oblique overaction. And that is by Herring law. Okay. So Kushner reported this anti-elevation syndrome when you do this bilateral inferior oblique anterior transposition. And he correlates the frequency of this syndrome with the amount in millimeters of lateralization or a lateral displacement, I mean spreading the muscle of inferior oblique reattachment site. As let's say if you put it more temporarily, you spread it temporarily, this will get more anti-elevation syndrome. And they concluded that these anti-elevation syndrome may be prevented by attaching the posterior fibers of the inferior oblique muscle no more than 2 millimeters lateral to the inferior rectus muscle insertion site. So how does they help, please? Okay. Okay, and I'll call you again. Okay, thank you. And well, this anti-elevation syndrome, what I want to do is show you how it. Okay, now this little girl, if you see the left eye goes when it turns. The left eye goes up, the left eye can't go up, and that's an anti-elevation syndrome. This girl was operated of a DVD, and when she attempts to move the eyes up, she can't. And in one eye, and the other eye goes up, and that's what we don't want to do. That's what we don't want at this anti-elevation syndrome, and it occurs in like 20% of the cases with standard procedures. So, and which are the standard procedures? The standard procedures are when you reattach the inferior oblique temporal and anterior to the inferior rectus insertion. And the inferior oblique reattachment also temporal and beside the inferior rectus insertion, and even it comes with a 20% incidence when you reattach it temporally and posterior to inferior rectus oblique insertion. So what's the purpose of this study? Is to present a modification of the classical inferior rectus anterior transposition that significantly reduces this anti-elevation syndrome, reattaching it immediately beneath the inferior rectus muscle insertion. So we enrolled patients since 2006, and the inclusion criteria was were DVD associated with moderate to severe inferior oblique overaction, horizontal deviation, which may coexist, and they underwent a symmetrically modified inferior oblique anterior transposition and immediately beneath the inferior rectus muscle insertion. Patients that were excluded when they had DVD without inferior oblique overaction, or restrictive or paralytic deviations, prior vertical or oblique muscle surgery, or patients who did not reach the 12 months follow-up. So this is the modification of the technique. I'm going to show it to you. We dissect the muscle, suture as usual, at the lateral temporal insertion. And then we cut it, and instead of reattaching it beside the inferior oblique, the inferior rectus, there you go, instead of putting it there, we just slide it down the inferior oblique, the inferior rectus, and we reattach it with a suture beneath the inferior rectus. And what we thought that comes to treat the DVD really good, because we are doing this anti-elevation opposite to the superior rectus. So when the DVD calls, and the brain calls the eye up, the inferior oblique restricted. So that's how it works. And if you have it, you can see this again. And if you have opposite forces, then this will work really good. And it's really, at first we started to put the inferior oblique, trying to insert it to the sclera, just a little bit behind of its insertion. But after a while, that was really difficult. It was really difficult to do so. So it was really, it's easier to do it this way at the insertion, and technically it's easier. So we did 101 patients, and from the 20% that always get anti-elevation syndrome, we only had 3 patients, that's a 3%, that showed anti-elevation syndrome, but it wasn't really big. It was a really small one, but it did. And 25 patients, 25% had corrected the DVD satisfactory. That means plus less 10 prism diopters. And we had a follow-up average of 18 months. Well, here's some pictures of the eye, and where's the, oh, here. And what you can see in elevation, in supraversion, supralateral versions, there is restriction, but it's symmetrically. No inferior oblique overaction over here. The eyes just don't, they're not asymmetrical. And here is, I can show you a preoperative patient, and see here he has an esotropia, and a DVD that's coming up. It's asymmetrically, and now you can see this asymmetric form of lateral version. And here again, the inferior oblique, it's going up. Here also, and when it comes to, see here. And now, like 2 years or 4 years, 2 to 3 years postoperative, you see no strabismus with almost anything at primary position. And here, when he attempts to go up, the eyes to go down. Well, here they go down, and here they go up, right? It's symmetrical. You don't see that again. See? Okay. Here's the next one. Oh. That's another. Oh no, it's the same one. It's this one. Doesn't connect again. I'm having trouble again with the video. Okay. This is the other. It's another patient. Here again, you can see the inferior oblique overaction. See, here it goes up. Downward positions also. And well, I wanted to show you how in the post-op, really immediate post-op 7 days, you can also see the same thing. When you go up, there's restriction, but both are symmetrical, and no anti-elevation syndrome appears. And this is good. What it's good about the technique, that it's really simple. Instead of putting it temporal of the inferior oblique, of the inferior rectus muscle, you just put it beneath the insertion, and that is pretty. You have pretty good results. And well, our conclusion was that inferior oblique anterior transposition immediately beneath the inferior rectus insertion significantly reduces the incidence of the anti-elevation syndrome. And well, thank you very much. This is La Paz, Bolivia. Last year was called the new 7 Wonder Cities, and you're welcome anytime. Thank you. You have questions? Yeah. Well, patients that have those strabismus, generally comes with what's called a congenital or infantile esotropia, and they comes that the two eyes don't come together, so there's no cereopsis, and probably there's suppression in both eyes. And well, since this appears in the first few months of age, really, if you correct them as soon as possible, probably cereopsis comes to be better. Actually, there's a lot of papers of treating amblyopia or cereopsis in older patients, and I think there's a really good research coming up with one of the softwares they're using. But well, when you correct the children, the faster it restores the vision pathways and cereopsis and so on. That makes sense? Okay. Anyway, and some another question. Is there another question of other papers? I think Miss Venezuela wanted to come. Okay, now she wanted to present something. Do you want to eat something and do that, or maybe we can finish this up? I don't know if there was one. Uh,